in the pulmonary vasculature. It is defined as an increase in mean pulmonary arterial pressure of more than 20 millimeters of mercurium at rest by right heart catheterization. This definition changed in 2018 because since 1973, after the first symposium on pulmonary hypertension, it has always been 25 millimeters of mercurium. This cutoff of 20 is adopted by the European Society of Cardiology, but not yet by the American Heart Association, neither by the American College of Cardiology. So you might be reading in some reviews 20 and in some 25. That is the reason. It can be caused by increase in pulmonary blood flow, pulmonary vascular resistance, pulmonary venous pressure, or a combination of these. The epidemiology is largely unknown apart from group 1 pulmonary hypertension, which is pulmonary arterial hypertension, and most data are derived from specialized registries and referral programs rather from the general population. There's a prevalence of about 32% that was found in a pooled sample of 2,000 patients with left heart failure from 3 studies carried out in Morocco and Nigeria. And in the Vavafric study by Professor Kinge and others, 13% of patients with rheumatic heart disease were found to have pulmonary hypertension. In a pooled sample of patients with sickle cell, in 171 patients, 36% were found to have pulmonary hypertension. And among a global number of patients who came for cardiac complaint, almost 10% had pulmonary hypertension. What are the signs and symptoms? They are very vague. Patients could have dyspnea, shortness of breath, lethargy, elevated jugular venous pressure, the abdominal pain. The signs could be, as we earlier said, they could have hepatomegaly, leg swelling. What are the potential diagnostic modalities of pulmonary hypertension? There could be chest X-ray that will show cardiomegaly, ECG that can show right axis deviation, right ventricular hypertrophy, right bundle branch block, echocardiography, which is what we all use for the moment to diagnose pulmonary hypertension, and we will get a bit deep into that. The gold standard for the diagnosis of pulmonary hypertension is catheterization. Dr. Ambassa showed us a good picture yesterday of a cath lab owned by the Chisson sisters. So, going to echo, because it's the one that is mostly used, we have various methods that we can use to assess, to have a probability of pulmonary hypertension. Remember, echo can give you only a probability because the definite diagnosis is by right heart catheterization. So by echo, you could use the peak TR velocity, which is the most used, but if you are able, those who are more versed with echo can use pulmonary artery using the pulmonary valve regurgitation velocity to have an estimate of pulmonary pressure. Of course, the peak TR velocity is used together with the IVC to have this idea. This is an example of tricuspid regurgitation with our continuous wave Doppler. We can measure the peak of the TR velocity and use the Bernoulli equation to derive pulmonary pressure together with the right atrial pressure. Remember that when you are doing this, you from that picture, make sure, as I say, to measure the chin and not the beard. So make sure you don't overestimate. I earlier said that that pressure can be measured together with an estimate of the right atrial pressure that you can get from the inferior vena cava. Depending on how dilated it is and the respiratory variation, 5, 10, 15, or 20 millimeters of mercurium are added to what you get from the TR regurgitation jet. Now, as we earlier said, echo can give you a probability. So what is this probability on echo to be able to say a patient has pulmonary hypertension or no? That is, if you have a jet of more than 2.9 to 3.4 meters per second, then you can comfortably think that patient can have pulmonary hypertension. If you have a jet of less than 2.8 meters per second, it is less probable that the patient has pulmonary hypertension. Also, if you have signs of PH signs, that is a very dilated right ventricle, then it's a bit more convincing. According to the Sidwell Symposium on Pulmonary Hypertension, pH can be defined as pre-capillary pH, isolated post-capillary pH, which is the one which is for pH due to left heart disease, or combined pre- and post-capillary hypertension. This is found mostly in patients with left heart disease in whom the pulmonary hypertension is not only an increase in venous pressure, but also due to modulation of the pulmonary vasculature. Pulmonary hypertension is classified in 5 classes. Number 1 is the pulmonary arterial hypertension. This is very important that we know that these two entities should not be confused. Pulmonary arterial hypertension and pulmonary hypertension. PAH is a subset of PH. Number 2, since we are running out of time, we are going to go through it very fast. Number 2 is PH due to left heart disease, which is the most common. Then we have due to lung disease, due to thromboembolic pulmonary occlusion, or the feed where it's not very clear why the patient has PH. Now we go straight to what interests us, which is the algorithm. This is the 2015 ESC guidelines. I hope it's clear. It looks a bit blurred even for me. Anyway, if you have patients with symptoms or a history which is suggestive of pulmonary hypertension, you do the echo. When you do the echo will give you a probability of PH in that patient. We already saw what are the cutoffs that will permit us to say if the patient has a low or a high probability of PH. If that probability is low, then consider other causes of why the patient has those symptoms. If not, you can even do a follow-up and recheck to see if after some months the patient the pressure has increased. Then if that risk in echo is high or intermediate, that means the patient has a jet of more than 3 or 2.8. Then you have to consider if the patient has lung disease, has left heart disease, and all these informations, chest X-ray, ECG, and echo can give you that. Now, if you have a diagnosis, if the echo and all the rest, they give you a diagnosis of left heart disease, then if there are no severe symptoms, signs of PH or right ventricular dysfunction, you treat the underlying disease. Treat your lung disease, treat your heart disease. But if there are signs that there is severe right ventricular dysfunction already, then that patient should be referred to a PH expert center. If you have excluded left heart disease and lung disease, then you have to do a perfusion scan to be able to exclude thromboembolic pulmonary hypertension. If there's no thromboembolic pulmonary hypertension, with angiography, you do a right heart catheterization that will be able to tell you if pulmonary arterial hypertension is likely or not. And when is this likely? When during right heart catheterization you have a mean arterial pressure, you can see here is 25, as I told you earlier. If you have a mean arterial pressure of more than 20 or 25, be it European or American, and then you have a wedge pressure of less than 15 and a pulmonary vascular resistance of more than 3 Woods unit. If it's not PH, if you cannot identify pulmonary arterial hypertension in all its different classes, that is PAH due to HIV, due to drugs, due to irritable conditions, due to, I don't know, if you cannot have any of all congenital heart disease, then you don't know what the patient has. So that goes to number 5, where it is unclear. That said and done, we know we have very limited resources. Apart from what the center with Dr. Ambassa, I don't know if we have centers like in Europe where every region has a cath lab. And how many patients can do catheterization to have a definite diagnosis, but we need to manage these patients. So PAPUCO study is a Pan-African Pulmonary Hypertension Cohort Registry, the first of its kind, that was made to give us a helping hand on how we can diagnose hypertension in a low-income setting. So, in their study, they found all the 5 classes of pulmonary hypertension in Africa. Okay, and then of course, as in other registries, the group 2 was the highest. I need to know if I'm on time, please. And then, according to their algorithm, if you have patients with signs and symptoms suggestive of pulmonary hypertension, you do your clinical exam. If the clinical exam is still suggestive the patient has edema of lower limbs, dyspneic, and all of that, then you can do a chest X-ray and an ECG. The ECG could show you those signs I said earlier: right ventricular hypertrophy, right axis deviation. The chest X-ray can give you cardiomegaly. All of that will increase the possibility that that patient could be having pulmonary hypertension. So if that is the case, you do the echo. The echo will give you the different probabilities that we earlier saw in the other slides. If all of these are not suggestive of PH, then you look for other causes of dyspnea and all of that, which could be TB, which could be COPD and malignancy and all of that. So if the patient, if echo then shows, yes, there's pulmonary hypertension, but this patient has left heart disease, what do? You treat the patient for the underlying condition. If it does not show that there is left heart disease and chest x-ray and other exams do not show that the patient has lung disease, then consider common causes of pulmonary arterial hypertension in Africa, which could be HIV, could be sickle cell disease, could be whatever. Anyway, so if it's not a group 1, then it could be a group 3, which is a PH due to lung disease, and less probably common, you have group 4 and group 5. So the conclusion of the Pabuco study, it confirms that the PH due to left heart disease is more common, then followed by PH due to HIV and PH due to lung disease. Women are mostly affected, and most of the patients arrive late to consultation when with very severe symptoms. So for what are the take-home messages? There are 4 steps for the diagnostic algorithm: a clinical evaluation, chest x-ray and ECG that we can comfortably have, and echo that many hospitals and clinics now have to explore these etiologies and be able to classify pulmonary hypertension. Thank you.
Thank you, Dr. Sira Abang. You have done 12 minutes. Okay.